Welcome and good evening. My name is Richard Mehta, and I will be your host for this evening's educational session. I work as a sales consultant for Rehab Care, and I can be your point of contact for any support queries you may have after this webinar. We appreciate you taking the time out this evening to join us. Tonight's webinar follows on Brett's three-part webinar series on low-level laser therapy. He will build on last year's learning, and this time will focus on evidence-based clinical applications of low-level laser for pain management. If you have missed out on any previous webinars, please reach out to us for a copy of this recording. We will hold a Q&A question session at the end of this presentation, but please feel free to type in your question in the Q&A inbox at any point during the presentation. Without further ado, please welcome Brett Jarosz.
We'll get into this webinar, which is, as we heard earlier, continuation of the 3 webinars we did last year. I want to try and build into some more of the clinical applications. You know, it's important to understand the science, because if we understand the science and the physiology, we have a better understanding of what we can then do clinically and how we can utilize this type of technology. And then, of course, having some ideas of different protocols and some of the things that have happened clinically, so that you've got some of that evidence and experiences that have happened clinically that you can sort of fall back on, is also handy to have. So that's where we want to go today. And then, as we just heard before I came back online just then, there'll be some seminars face-to-face where we will be able to go in depth into more of the hands-on applications, actually going through using the technology, linking it with different other modalities, hands-on treatment, so manipulation, soft tissue in combination with laser, different assessment things, etc. So we're really looking forward to using this one as a stepping stone building block into that. So disclosures for today, as always, the main thing that I really want to emphasize in the disclosures is this presentation is not intended to diagnose, treat, or cure any medical disease process. Clinical and research information provided is intended to support the normal adaptive physiology of the human body, and certain treatment applications may be off-label in relation to FDA approval, but all topics presented have research to support the treatment applications. Now, that statement there at the very end, everything today I'm going to present to you is on label. All of the protocols I'm going to show today are straight out of the literature, but where you'll see the off-label is I'm actually going to show you guys another fracture case today that I worked with. So yes, it relates to pain, but obviously it has a relationship to healing and recovery of healing too, which we know there is evidence for that in the literature. So the webinar today will overview those scientific mechanisms again, so that we've got our sort of true understanding and how this works and the differences between the technology. So the difference between laser, infrared, LEDs, and then obviously high power, low power. And then we'll go through some of those pain management specific research applications. So in the introduction, low-level laser therapy, it's been around since the 60s, but it's been developed into a therapeutic procedure that is used in 3 main ways. And those 3 main ways are to reduce inflammation, edema, and chronic joint disorders, to promote healing of wounds, deeper tissues, and nerves. That's literally how laser was started. But it was a wound healing that recovered quicker, and the healing of actually of hair that recovered quicker. And then obviously treatment of neurological disorders and pain. And that idea of pain, you could tie 1 and 2 a little bit together there, inflammation, pain, etc., working together from a neurological perspective. So low-level laser therapy, or triple LT, 3LT, unlike other medical laser procedures, triple LT is not an ablative or thermal mechanism, but rather a photochemical effect. So we know that we've got surgical lasers. We think about some of the eye procedures that are now done, laser surgery for eyes. We think about surgery that's done under anesthetic, etc., where they'll use lasers to cut through skin, to cut through cornea, etc., to do these surgeries. And then we've got the other thermal lasers, which we'll discuss more later today, which is a class 4, class 3B lasers also. But as we get to these higher power lasers, we'll discuss what that means later on too. The mechanism of these lasers is a photothermal effect. So they have a heating effect, Whereas the low-level lasers that we're going to be discussing today, the EVRL in particular, the way that low-level laser therapy works is via a photochemical effect. And the comparison there is to photosynthesis in plants, where the sunlight's absorbed by the plants, and then you have a chemical exchange and change within the actual plant. So same principle, light absorbed by us and have a photochemical effect. So within low-level laser therapy, the light source and dosage is particularly important. And we'll talk about this biphasic dose response, as there is an optimal dose of light for any particular application, and doses higher or lower than its optimal value may have no therapeutic effect. So that is the underlying principle of hormesis. It applies to strength training with weights. It applies to pharmaceuticals and prescribing drugs. It applies the same thing to low-level laser therapy. So hormesis is the term there. So the evidence for low-level laser therapy, we've got randomized controlled trials with positive outcomes published on osteoarthritis, tendinopathies, wounds, back pain, neck and shoulder pain, post-surgical pain, heel pain, toenail infections, acne, muscle fatigue, peripheral nerve injury, strokes, body sculpting, fat loss. And the ones that are in that teal color, the green blue color there, they are all of the topics that Erchonia and the EVRL device that we're discussing, along with their red lasers, along with their green lasers. These are all of the ones that have got RCTs and FDA clearances performed by Erchonia themselves. And we'll discuss some of those clearances a little bit later. So the overview of the scientific mechanisms. So from the first couple of webinars, we understand that the first law of photobiology states that for a low power visible light to have any effect on living biological systems, the photons must be absorbed. So the key takeaway is the light needs to be absorbed by our tissues, and it has to be absorbed in some form of photoacceptor or chromophore. If light's not absorbed, it hits the tissue and deflects, or it scatters. So the scattered photons, when they're bouncing around, they may get absorbed, or they may bounce off in a diffuse reflection. So takeaway is we need light to be absorbed. When we look at the picture there on the right of the slide, we're seeing red light there, and this is where all the research had really been getting done until the last few years. I want to say a few years, I'm literally talking the last 3 years. The research had all been done on red light, so red colored wavelengths. Go through those wavelengths again in a second, but we're talking about that 600 to 660 nanometer range. We'll have a picture again so you can get your mind's eye back onto that one. But red light is absorbed in complex 4 of the electron transport chain within the mitochondria. So cytochrome C oxidase is that photoacceptor. So it's red light in complex 4. And so that absorption, lots of study on that. So it's a mitochondrial effect of the red light, the red wavelength, the red color is the one that gets absorbed into complex 4 in that electron transport chain of the mitochondria. So when we look at the physical mechanisms, the key takeaway when we're looking at the mechanisms of low-level laser therapy, and this is important, remember that your high-powered lasers, our class 3B, class 4, we'll break those classes down again in a second, but these lasers are primarily infrared. And the infrared wavelength that you can see there on the far right of that picture is in that wavelength of 800 nanometers. Infrared is absorbed by water, okay? High-powered lasers, infrared's absorbed by water, and it makes water molecules vibrate and oscillate, and that vibration, that mechanical effect, creates a heating effect, and that is our thermal effect that we get through that infrared and the high-powered lasers. When we look at low-level laser therapy and this photochemical effect, it has to do with the wavelength. It only depends on the wavelength. We're talking about the color. That is what the emphasis of low-level laser therapy is, the color of the wavelength, and the color has particular photon energy. So there's an energy to each wavelength. So if we look at the slide there, again, we go to infrared, the wavelength's 800 underneath it. And then the number below it, we can see is the electron volts. The energy of the photons in infrared is 1.5 electron volts. And as we move to obviously the left there, we've got the red wavelength. And that red color is, as we said, somewhere between 600 and 660. And that's electron volts there of about 1.9. We get into the green wavelength, 510, and it's electron volts of 2.4. And then we get to our violet, and of course the EVRL that we're talking about here from Erchonia is violet and red. So we have a 3.1 electron volt, and we have a 1.9 in the red wavelength. And so at the bottom point there is you can see that violet photons have more energy, 3.1 compared to 2.4. So more energy than green photons, and green has more energy than red, that has more energy than near infrared. So when we're talking about this photochemical effect, it's got to do with the energy due to the color of the light. Again, the AKA is wavelength. When we say color of light, we're talking about the wavelength. They're sort of synonymous with each other. So the wavelengths and the effects on mitochondria. So we know that low-level laser therapy involves the mitochondria, and it's got to do with the electron transport chain. So if you go back to our school, you can see my cursor here. We can see our electron transport chain, complex 1, complex 2, complex 3, complex 4, and then complex 5. So that process here, it's all about creating an electrochemical gradient through these 4 complexes that then moves across into complex 5, which is ATP synthase, and complex 5, that flow of electrons creating that gradient is termed oxidative phosphorylation. This electron transport chain with the electrochemical gradient and the creation of ATP, we refer to that as our oxidative phosphorylation, happens in the cellular respiration as well as in photosynthesis. You can't create this process with infrared lasers. As we said again, infrared is absorbed by the water. Side note, think about it. Our infrared saunas, we're going to these saunas using infrared light. We're no longer, well, we've still got the old saunas with the rocks in them and you heat them up and put the water on them, etc. But now we don't even have that. We've just got infrared lights in there. And how does it work? Because the infrared light is absorbed in water, creating that photothermal effect in your body. So as we said, the electron flow starts at complexes 1 to 2 to 3 to 4, and it makes ATP once it reaches complex 5, ATP synthase. Low-level laser therapy, as you can see here with the colors, targets complex 1, 2, 3, and 4. So violet targets complex 1 and 2, green targets 3, and red targets 4, which leads to the enhanced synthesis of ATP. So if we enhance ATP synthesis, we enhance cellular function. And obviously, apart from fully mature red blood cells, we have mitochondria in all of our cells. And then the importance of that hormesis, that biphasic dose response in low-level laser, is we've got this biphasic curve to illustrate the dose response to light. And we can see here, if we don't have enough energy, all right, down here, that we do not get a response. Get a little bit of response here. And then if we get enough energy, i.e. getting enough of the wavelength, enough of the color over time, so we keep that laser on the tissue for a period of time, then we start to get our stimulation. So we're stimulating. But if we keep the laser and the light on for too long, then we can start to get bioinhibition. And so through here, of course, our goal would be to have someone up here in the top of the curve. You know, here we're still getting an effect, but we're getting decline in that. So we're getting bioinhibition. So our goal is to be up here, not to be coming down here. And of course, definitely not to be getting below 0 when now I actually have the negative effects and detrimental effects. And so we can see the energy here across the bottom. And one of the things that's the easiest way to remember this very basically, because there are formulas that we use for this whole energy process with laser therapy or light therapy, photobiomodulation, but it's just simply for simple purposes, take joules. And when we look at wattage, if you hear of a laser is 1 watt, just equate that is 1 watt equals 1 joule per second. So if we're looking in this range here, and we'll see most of the biphasic dose, so this hormesis, if you look at the laser research, which will show, we've got research on this with the data of where these numbers occur, but basically we're looking in this range of about 1 to 10 joules is where we want to be stimulating people. We do not want to be really getting above 10 joules. This is, and especially we don't want to be getting into the 30 to 50 range. So our range here is basically between 1 and 10 joules. We want to stimulate. So if you just do the math with that, if you had a 10 watt laser, that means you could only put that laser on them because 10 joules, 10 watts is 10 joules per second. So if you had a 10 watt laser, you could technically only put that laser on them for 1 second. And what we know is we need light to be on there for longer periods for better absorption for the therapeutic effects. And again, not that we encourage this any today in today's day and age, but the idea of getting a suntan, you do not go out in the middle of the day at 1 o'clock in the middle of highest potent UV and sit out there for a long period. Why? Because the sun has detrimental effects if we're out in it for too long. But if we get out in that sun, low level, mornings and later in the evenings when that UV is not as high, and we gradually expose ourselves to light over time, we know that we get those beneficial responses of light. So obviously vitamin D and we think of circadian rhythms, etc., all those different things of how light works. But the analogy of too much light, we can think of that as our UV, middle of the day. We don't do that for a suntan. Not that we do suntans anyway, but the analogy works for this purpose. So differences between the technologies, we've started hinting at a lot of these. Let's go back to the classes. The classes of lasers are based upon the potential for causing injury to your eyes and skin. That is how the classes of laser works. So class 1 and class 2 are relatively safe for eye exposure. So we can see that's down here, and look at the range in wattage. Okay. Class 2 laser, you can see here is in this milliwatt range. Okay. This low milliwatt. Once we get to this 5 and above, 500 milliwatts, above 500 milliwatts, this is where we get these increased classes, class 2 to class 3 to class 4. We know the last two classes, class 3B and class 4, are our hazardous laser classes for our human eyes and for our skin. So you can burn someone's skin with these lasers. Obviously, you can damage their eye. The human blink reflex is not fast enough to protect our eyes from those lasers. So the eye injury hazard increases as the laser power increases, as we can see here. And most of the class 4 lasers that you guys will come across as healthcare providers, when we're being sold them, you're being told, you know, get a 20 watt, get a 30 watt, get a 40 watt laser. More power decreases your treatment time. Or rather than saying that, it's not that it decreases your treatment time, it's actually you can't expose someone to light for that long. If you've got a 40 watt laser, you've just already put 40 joules in a second into them. You've already exceeded that biostimulation dosage. You're into bioinhibition and into that detrimental effect range. So understanding our classes of lasers in terms of power, understanding wavelengths, you can see the importance of this and some of the misinformation that we are fed as practitioners with different light therapies, LEDs, which we'll come to, class 2, class 3, class 4 lasers. Also, even in the research, when we look at the literature, we can see research that talks about photobiomodulation doesn't work. But unless you understand different wavelengths and different classes, you can't put the term photobiomodulation across the board, because a lot of these systematic reviews that are out there, in a recent one was saying photobiomodulation for low back pain doesn't work. But if you look at the article and the articles they included into that systematic review, it was 8 articles and all of them were infrared wavelengths. They were all over 800. They were in the 800, 980 nanometer ranges, etc. That's not photobiomodulation, that's infrared wavelengths. So even within the research, there's a misrepresentation and poor terminology being used, which again leads to further sort of misunderstanding from us as healthcare clinicians trying to help patients. So trying to understand this here now, navigating our classes work. It's about eye and skin damage, understanding it's got to do with the power, so watts, milliwatts, etc. Understanding that 1 watt equals 1 joule per second in terms of energy. Link that back to hormesis, and we know where our dosages want to be. We want to be between 1 and 10 joules. And we know for best therapeutic effects from a photochemical perspective, we want to be able to expose the tissues to that light for a longer period of time where possible. So our wavelength and our energy again, we've got photon energy measured in electron volts. We talked about that before. We know the shorter the wavelength, i.e. coming over here to our gamma rays, Bruce Banner, the Hulk, shorter wavelengths, obviously our X-rays, our UV. Then we get into our visible light range here. Through this range, we can see that the shorter wavelength has a greater electron volt. And as that wavelength gets longer, we get less electron volts. And as we can see here, 405 nanometer, which is where we get into our violet, has 70% more energy per photon. And remember, energy and power, different things. So when you hear the word energy, think electron volt, think wavelength. When you hear the word power, we're thinking about the wattage of the laser. So the machine wattage versus the color of the wavelength of the light that comes out is the energy, the photon energy, the electron volt. And again, that is another point of confusion because people interchange the word energy and power. And you've got to make sure that when people are discussing it, that they're clear on which term they're using. Power is the wattage, energy is our electron volt, the color of the wavelength. So when we look at some of the literature here, visible and infrared affect a biostimulation in different ways, which I've already talked to you guys about. Visible light, all right, so our red through to that violet wavelength. So visible light elicits photochemical changes, the electron volts, photochemistry, absorbed in the mitochondria, complexes 1, 2, 3, 4, producing ATP. Where infrared only produces physical changes, absorbed by water, the mechanical vibration oscillation creates the photothermal effect. And again, another article, although visible light can produce photochemistry, obviously the same comment from the article before, infrared radiation only produces molecular rotations and vibrations, in particular in the water molecule. And then considering the low quantum energy per photon for the 785 to 905, so infrared, so the infrared range is equal to 1.52 to 1.37 electron volts. If I jump back to the previous slide, we can see that here showing that 830 is in that 1.49 electron volts when we start to look at the infrared. So you can see over here, shown down here, 1.25. As we move further into the infrared range, we can see that that electron volt gets less. So 830 nanometer has about 1.49. So it's showing you here that in that 785 to 905 range, there's basically a 1.52 to 1.37 electron volts in those wavelengths. Those wavelengths apparently do not induce direct photochemistry, as the minimum quantum energy is in the order of 1.7 electron volts. So when you come back to this, basically we're saying we need to get a color red wavelength. So we're talking about probably 660 is going to be our end range there to be getting the wavelength, the color to have enough electron volts to have that photochemical effect. And then, of course, this argument that's always out there about you need more power, so you need more watt in your laser for depth of penetration. And again, this argument is, again, the argument, I've got slides in webinar 2 to show you depth of penetration through skull with the different wavelengths. And the interesting part here, as we know, is water won't absorb the visible light because it's too energetic. It's got too many electron volts, too much energy. So water doesn't absorb that, but the infrared light spectrum, it gets strong absorptions from the water molecules. And as we've heard me say before, infrared absorption is heating of the tissue. Since it increases the molecular vibration activity, we get that photochemical effect. This is a great slide. This comes out of University of Georgia or University of Georgia Tech, their physics department, where it's just talking about, if you look at the ocean and we look at the color of the ocean, what is it? The color is like blue-green. And then you understand why when we can understand that the energy in these wavelengths, they are the ones that penetrate deeper. So the color of the water is blue-green because that's the color of the wavelength that can obviously penetrate deeper into the water. Whereas, as you know, when you stand in the water, the top of the water is warmer. Deeper you get, the colder it gets, because the top of the water, that's where the infrared wavelength's being absorbed. And so the top of the water is obviously heating up. So top of the water is warmer. Deeper you get, the colder you get, but the color is that blue-green. So we can start to get a bit of an understanding of the colors and how our light absorption is working in that example of the ocean. And then we get into this LEDs and broadband light. And so the big thing that we want to talk about when we're comparing like LEDs, broadband lights with lasers is that it's this monochromacity is much more significant for light absorption. So basically, a laser, because we've got the light traveling in one single direction here, we can see this in the bottom of the slide. We've got one wavelength, so 635 nanometers or 405 nanometer wavelength, traveling at the same speed and the same direction. Whereas if we look at, say, an LED, we have this broad, like wide spectrum. So you can see it's fanning out. It's the same color. So we've still got 635 nanometers here, say, and we have 635 nanometers here at the bottom. But because we've got that light traveling same speed, same direction here, we get better absorption versus the LED. Because it's fanning out and it's not being directed in a straight line, we get more scatter. We get less absorption from the LEDs because of that broad spanning out. So we know from the literature, the illumination from the laser absorbs several times more actively than this incoherent light with a larger spectral width. So this narrow pinpoint laser light compared to the broad, wide LEDs got to do with absorption versus scatter. When we put that into research, every Erchonia study, their sham, their placebo that they use in their studies is an LED of the same wavelength. So when we look at this particular study, which was, this is Erchonia comparing all of their pain studies from heel pain to back pain to neck and shoulder pain. So what we can see here is this is where the pain started in the group. The solid line is the laser group. So when they were exposed to the 635 nanometer red wavelength, that was the decrease in pain. And you can see with the LEDs, they use the same wavelength, red LEDs, and you can see you still get improvement, but you don't get as much improvement with the LEDs. Again, why? Because of that broad, wide, less absorption, more scatter. So that's the difference. But the interesting part is when these people, treatment ended here, okay, on the slide on the right. So we've still got our laser therapy. We've got our LED, our sham, our placebo. So we get improvement with the laser. We get improvement with the LED. But once treatment stopped here, we can see the laser, because you're having photochemical effects, improving the electron transport chain within the mitochondria, we can see that because of that alteration in photochemistry or biochemistry, if we put it done via light, so photochemistry, we can see there's continuous improvement that continues after the treatment ends. Whereas we can see with the LEDs, there's actually some regression and we don't have that continued improvement over time. So basically saying, got to keep using the LEDs. The FDA clearances, the important part here is if you jump on the FDA websites, obviously FDA, you've got to do randomized, controlled, double-blinded, placebo-controlled studies in order to get FDA clearance. Or your other option is you say there's already a device that's out there that's been cleared via research. I'm going to build a laser based on technical equivalence, and I'm going to submit my laser to the FDA to say this is basically the equivalent of what these other lasers are, and I'm seeking clearance. So you can get substantial equivalence, or you can get proper FDA research-based clearance. And when you look at the FDA websites, it'll tell you whether it's a substantial equivalence or whether or not they've done the research. But when we look at class 4 lasers, so these lasers over 500 milliwatts, they are cleared, like medico-legally, they are cleared under the ILY product code. And the IOL category started as a heating pad, and now it's expanded to thermal lasers, which are intended on the FDA website. The clearance of an class 4 laser is to provide topical heating for the purpose of elevating tissue temperature for temporary relief of muscle and joint pain and stiffness, arthritis pain, or muscle spasm, the temporary increase in local blood circulation, and or promoting relaxation of muscle. So when we're using a class 4 laser, understanding that we are using that laser as a thermal heating device, but not as a laser with a photochemical effect. Important to understand the differences. Does that work? Yeah, people can use this material and it helps. Heating, placebo effect, blood circulation, etc. So the class 4 lasers, understanding what they have FDA clearance for, and they are now, as you can see here, FDA has now made the ILY products exempt based on the device requirements of raising skin temperature to 40 to 45 degrees. And we can get into the negative effects of doing that to people as well, but where they got clearance is as a topical heating device to elevate tissue temperatures. That's what class 4 lasers do, and it's important to understand so we understand why I want to use certain light sources for certain treatment modalities. And then obviously, if we want to have these photochemical and cellular effects, where we really want to be going is with our low-level laser. If I want to put a heating device onto someone for that temporary relief, for whatever clinical reason you want to use that, you go, I've got another option there in a class 4 laser, etc. So evidence-based clinical applications for pain management using the EVRL. So when we obviously talk about this EVRL, we are talking, this is, I've got the old one here with me here now. The newer one is much cooler, easier to hold on to. It's a little bit more user-friendly with its interface. So since their founding in 1996, Erchonia has remained committed to the advancement of low-level laser therapy, which has allowed them to become the world leader in the field of low-level laser therapy. Now, I've put my cart to the Erchonia horse because these are the guys who have done all the research and continue to do all the research. The money that they make, that they put back into research to identify what are the things that work. So they've gone from the red, they've built into the violet, they now have done the research with the green into fat loss, okay? And they continue to put research, so they've got research studies going on with the Mayo Clinic right now on fat loss and health markers. So obviously a huge study going on. They've got studies going on now with brain and doing transcranial work. So they keep investing their money into research. And then as we can see here, through scientific and clinical studies, Erchonia has 21 different FDA clearances for low-level laser therapy, which is more than all other low-level laser therapy companies combined. And what's interesting is if you get onto a lot of the other laser companies' websites and their material and their promotional material, their marketing material, they're usually referencing Erchonia studies. And we can see that some of these laser companies are not at all low-level laser therapy at all. These often are class 4 lasers, and they're quoting low-level laser therapy research, which is not how it works. They're two different machines. So we have to understand that science and the research and these mechanisms so we can tease out the misinformation that's there. Okay, so since its release, the EVRL handheld laser, this one here, is the most popular handheld device. Obviously exciting because we got this device into Australia last year. It's been out in the States for a few years now, because it offers that versatility of the red and the violet wavelength, and that violet wavelength being the most energetic and influences complexes 1 and 2. And then we've got the red influencing complex 4. So we're getting 3 of these complexes being affected via the EVRL laser from a photochemical perspective. Just obviously some of the specifics there with the specifications as to how the actual diodes, the nanometers. So we've talked about the violets 405, 635. We can see our milliwatt range there. But one of the research studies that was immediately done, which I'll share in a second, showed by combining these specific wavelengths into one treatment modality, obviously instead of just having red and violet, by putting the 2 of them together, patients received better results in the clinical studies than when you just use the red alone. We'll go through that study in a second. So just what I want to just get into here, just to wrap up some of this evidence-based stuff with some case studies, is let's just look at the things that have been FDA cleared, where we've got the evidence for using the laser for particular therapeutic effects, such as in this one here with plantar fasciitis. So you can see that they did 2 treatments per week for 3 consecutive weeks. So we had obviously 6 treatments there. They just got 10 minutes of laser in each of the sessions. So session 1, 10 minutes of laser. They did that to the top of the foot, around the heel and the sole of the foot. So we had 10 minutes of treatment time around there. Let's just say they did that on Tuesday. They did it again on Friday. The following week, they did it again on Tuesday. They did it again on Friday. And we can see here that based on pain, this was obviously just a pain study, the mean VAS scores decreased from 67 out of 100 at baseline to 6.9. And obviously the treatment protocol you can see here, obviously was 6 treatments, and they kept following these people up over that time frame for 12 months. And we can see the changes that occurred. Just personal case study here for you guys. So 27-year-old professional female surfer, had a surfing injury. The ankle was forced into ankle dorsiflexion. They had an MRI, obviously professional athlete, happens the next day for these guys. So MRI of the left ankle was performed, showed a non-displaced cortical fracture of the anterior process of the calcaneus with mild adjacent marrow and soft tissue edema. I had a consult with the athlete 2 weeks after the injury. She hadn't been able to surf. She hadn't been able to do any of that type of training. Anytime she was weight bearing, she had an achy pain. She was basically doing some paddling on the surfboard and trying to do a stationary bike, but just pushing with her right leg, but just to try and maintain some form of conditioning, obviously trying to get ready for her next event if she could compete. So what we did there, as you can see, all I'm just showing there with her is that's just me using the EVRL point and shoot style. So the approach here was I just basically had that laser and trying to keep it perpendicular to the tissues, and I applied it for 5 minutes to the outside of the ankle region, and then I did it for 5 minutes on the inside of the ankle region. And we did that with the laser just over that area. So that's your point and shoot approach. I'll give you this numbers for a second of what the frequencies are from the research, but simple as that, just sitting there wanding that thing around back and forth, just covering that ankle region. Again, lateral aspect for 5 minutes, inside of the ankle for 5 minutes. And then of course, as we went through this, we added in some mobilizations with our hands, soft tissue therapy through calf, lower limb, foot, etc. And then of course, moving into like toe and ankle sensory motor and strengthening exercises. But why I wanted to share this was because, as we know, like the strengthening stuff, that's going to take time. That's going to take weeks to get those changes. The soft tissue therapy, obviously you can get some relief with that and the mobilizations, but this was the bit that blew me away with that laser, was following the second treatment. And first treatment that we did with her was basically laser, and obviously I'm not going at a fracture initially in terms of any mobilizations, etc. We just basically did the laser. We did a little bit of soft tissue work. So after the second treatment, she reported feeling good. Actually feel that her right ankle might be more sore and noticeable than her left. Couple more treatments, obviously, with the laser. So again, we did 6 treatments over the course of 4 weeks. And with the giving her homework, she had her toe exercise, her ankle exercises. After the 5th treatment, she reported that her ankle felt great. And then obviously I've got all of my orthopedic testing and other strength testing, etc., that we did. But the bit that blew me away was just that first sort of treatment with the laser, second treatment with the laser, and then she's reporting that good. But after the 6th treatment with the laser, so 4 weeks after it, she was returning to surfing without pain aggravation, and just a really nice, simple case of just using that point and shoot approach with the laser. So something a little bit more profound coming up next. So the point and shoot approach, we've got our default frequency settings that we plug into the EVRL, which is we use the violet at 9. So just remember, the frequency just means how fast that laser is, what you can see, how fast it's flashing. So 9 hertz is 9 flashes per second. Then you got our 16 hertz, 4253. Point and shoot approach, just try and keep the laser at roughly about 10 centimeters away from what you're trying to obviously apply that photochemical effect to. And your choices with this. So if I've got, there's something going here. So if I've got my finger here, obviously I can try and get this beam. Let's get in the camera. So I could get that beam at a point to cover my whole finger, use the line, or of course I could come in and get that beam more focal to the area. In fact, I could just put it straight over the tissues there. And I don't have to worry about burning because there's no photothermal effect there. So we can use the beam as a judge. If I wanted to go over someone's entire abdomen, I could hold this back far enough and have that wanding over the entire abdomen. So keep the laser perpendicular in orientation. That again allows the best absorption because we're getting more photons directed. If we're off on an angle, we're not getting those photons going directly at the tissue. So we want it to go straight at the tissue, not away from it. So for the best absorption, and we want to do about a 10-minute treatment duration, but 2 minutes is your absolute minimum. So again, it's about exposing the tissues over time. And if we look at that here with low back pain, low back's a bigger area. And as we can see with the research, and just giving a little bit of a plug here that you already heard from Sherelle, was Dr. Trevor Berry and myself will be presenting live hands-on seminars together later in the year, end of September, start of October. But Trevor here is the lead author, chief clinical investigation for this particular randomized controlled trial. And because the low back's bigger, they were doing 20 minutes to allow greater absorption of photons into that area. So we said 10 minutes is your minimum. Well, technically 2 minutes is your bare minimum, but generally our treatment times are about 10 minutes. But we can see with the lower back, because it's a bigger area, they did 20-minute protocols for the lower back to get greater photochemical effects for greater tissue area. And as you can see, 2 treatments per week for 4 consecutive weeks. So they had 8 treatments there. And we can see the changes in the pain scores again. Again, these were just purely pain studies. And so when we treated them with low-level laser, we can see the difference between the low-level laser and the LED, which again is the sham. So the placebo, the sham that Erchonia uses is always the same wavelength in an LED. So that way the people think that they're getting laser because they're still getting the same red color light looking thing, but it's not a laser because it's that LED that has that broad width to it. So we can see the differences there of 27.9 points between the laser and the LED. So another study here, basketball injury, sprinting, the athlete was sprinting on defense, felt like someone shot me in the back of the hammy. So the classic sniper up in the tree. You hear that straight away. We're naturally thinking obviously of a strained hammy. 9 days following the injury, hadn't been assessed, hadn't received any treatment, basically just done the rest, the compression bandage and ice. So they obviously walked in antalgic, limited swing phase of the gait. So immediately you're looking at that going, all right, that range of motion, eccentric aspect of that hamstring's affected. Doing the heel drag test, foot on the ground, pulling it back, that reproduced their pain. Lay them on the back, try and just do a standard hamstring stretch to obviously test it, not to stretch it, but to test it. They got to about 40 degrees, reproduced their pain. Manual muscle testing of the hammy at 9 and 15 degrees, 4 out of 5 with pain on both of those tests. Visible bruising, palpating the area, about 2 finger width defect, with you can feel that muscle tone being less in that mid portion of that left hamstring. So we're looking here really like a grade 2 hamstring test on the higher end of grade 2, not a grade 3 though, still had decent function there, but grade 2 hammy tear. Roughly what it looked like, that's not the actual case. It was a different case, happened to be able to sneak a photo. If you look at the management here, 4 treatments over 4 weeks, it was basically laser once a week, point and shoot, 10 minutes to the hamstring. So just basically over that hamstring area, holding that laser, 10 minutes, just wanding it, covering that area, doing all the different mobilizations, manipulations to basically from lumbopelvic down to ankle where needed, soft tissue work as it evolved, and then our hamstring rehab. This to this day, this was probably the first pain and orthopedic based study that had me sort of raise my eyebrows. So following the first treatment, so again, we come back, was 9 days after they've done a grade 2 with all of those tests there. First, after the first laser, so 10 minutes of laser, they had no pain with gait and almost looked normal. So their swing phase had improved out of sight. So it was no longer this visible limp anymore. They had no pain on the heel drag test. Their range of motion was equal to their other side. Their range of motion sucked. They didn't have very good flexibility in the hammies. And I could muscle test 5 out of 5 on both sides with no pain. Like, just blew me away. Now, do they still need to do hamstring rehab and all that? Yeah, of course they do. But that first treatment of laser and the difference, again, to this day, this was one of the, obviously we talked about the fracture case, which was my daughter, and the healing of that, to have a fracture that should be non-weight bearing. And we had that back playing basketball in 3.5 weeks. But this was the first one that I did something on an orthopedic and watched that change after the first treatment and just went, no way. So you can see some real amazing things through that photochemical effect. So study on the EVRL here was basically they took this device, they reproduced their previous neck and shoulder pain study, and they just applied one treatment with the EVRL, and we can see the differences with one laser treatment with the red and the violet. They got a better outcome than what they did with pain and range of motion compared to just red alone. So that was just in one treatment. And on this one, I'll just share a case study because this actually happened to me last week. The case is me. I said sleeping injury. I just woke up and I couldn't move my head and neck. Now, that being said, the day before I'd been doing some golf technique training, no injury, like I was absolutely fine. I had no problems that night, didn't feel anything, just woke up and I could not move my head and neck. So it was basically, that was me, could not go to the left. So the following day, all my ranges of motion were painful, couldn't go right, couldn't go left, forward, backwards, but could not move my head to the left. And when I tried to, real specific to that C3 area, cervicothoracic area, pain was like 6 to 7 out of 10 when I was trying to go to the left. The other directions I could handle better. But you can see the range of motion there about 1 day after. We're about 20 degrees to the left, 60 to the right. And then my neck extension just completely sucked. I couldn't go much further than that. Nothing with neuro testing, which is purely just, neck pain, looking obviously like a bit of meniscoid extrapment, most likely. So last week, treated it 3 times. I treated it myself, put it on the actual laser stand, looked in a mirror, found the spot, and then basically had the laser here, just put the violet over the SP, spinous processes, put the red over those nerve root areas, and basically just point and shot there because, hard to do this stuff to yourself. Just point and shot for 10 minutes. Second treatment, went through the downstream approach, which I'll talk to you guys in a second, which is where I went to like brain and then cerebellum and then neck, vagus, etc. And then third treatment, did another laser, and then I had my colleague treat me manually, and you'll see the changes in what basically happened last week. So put the laser on it, and it took 50% of the pain away on that first treatment, and my range of motion went from 20 degrees to about 50. And so even for me, I was sitting there going, this is really cool, having that device to be able to treat myself. And then the second treatment, pain got better again, range of motion got better again. And then with the third treatment with the laser and then those manipulations, obviously to free up those meniscoid extractments, facet joint stuff, the general terms. Yeah, basically range of motion restored. The only thing that was just left over is full range of motion, 4-minute extension. I can still just feel I got a little bit of lingering just there in that cervicothoracic on the left. But yeah, that was me just last week as a case study. So being able to treat myself with a laser helped me a lot to be able to drive my car. It was important for head checking in the car because I couldn't really do that too well going to work. But being able to use that laser and walk out of clinic, I was like, yeah, that worked pretty well. So if you don't see changes with the laser after 4 to 6 treatments, and you've seen just with those few cases there, specifically as it relates to pain, personally, I see a lot of complex cases, persistent symptoms after concussion, post-viral syndrome, chronic fatigue syndromes, centrally maintained vestibulopathies. I see a lot of this chronic stuff that people have had for a long time, haven't really got changes. So as a result, these upstream, downstream things tend to be the things I would utilize the most. And when I do have these pain aspects, in these incidences where I do see these acute injuries, this thing's been absolutely amazing. But for me, doing the chronic stuff, if I don't see these changes in 4 to 6 treatments, this is where we go to this upstream, downstream approach. We put a brain frequency into this that's a bit different to our pain setting. So instead of that 9, 16, 42, 53, we've got a 1, 10, 40, 60, which have got to do with brain waves. And then we can see how we do the upstream approach. If it was my neck, we would have gone over the area in the neck. Then we would have done the nerve root, spinal cord, would have went to the vagus on the same side here on my left. Then I would have went to the contralateral parietal lobe for the maps of the neck. And then I would have went to the contralateral prefrontal. That's the upstream approach, working from here, working up. Downstream approach, which is what I did to myself, same frequencies, went to the parietal lobe. But when I went to the parietal lobe, I just had one of those handheld massage areas and I was just gently going over this cervicothoracic area. So laser on the head, cervicothoracic here. Then I went to the cerebellum on this side and I was just doing infinity arm movements with this left-hand side, stimulate that cerebellum. Did the vagus nerve here on the side of the neck. Did the nerve root, which is the picture you saw previously. So that nerve root is that one. So we've got violet over the spinous processes, red over the, easy way to remember it, red over the nerve root, R and R go together. And then we do directly over that neck area of chief complaint. So cervicothoracic area was my main area to focus on when I did that one. Excuse me. Some of the advanced stuff, I touched on it. So some of the concussion stuff, depth of penetration, we went into that during webinar 3. There's a link there for you to review if you want to go into some of those more advanced things from last time. Colleague Tony Cassis shared a really wonderful case with a very complex neurological case that he had to show you the changes that laser made with that particular lady. And then, of course, from my perspective, I want to be able to go into a lot more of the hands-on demonstrating, doing these things with people in the room, which we'll be able to do in a couple of months in when we do these one-day seminars in Melbourne and in Sydney. So references always, they're there for you guys.
Thank you, Brett, for an insightful session. We appreciate your time tonight, and thank you all that have joined us tonight. A copy of this recording will be sent, and the certificate of attendance will also be sent shortly. And we hope to see you again on our other events. Thank you.